Oh, we have 2 minutes. 4. I have to plug my phone. Is there a plug here now?
Nope. I'm using my map.
I'll do it later.
This one
My
I'm gonna
computer
use.
was gone, so I had to. Then I'll charge my phone. So I did that. No, he's nice. So we don't have I'll use your phone. I have my charger here. So you'll be in charge of the camera. This is session 3 as well. And I present the speakers, is yeah, when we have them here.
I'll go up there. Sorry.
Sorry, I can go. Good afternoon, Montreal.
Ready?
Alors, si on pouvait demander aux gens de s'asseoir, if people can just grab a lunch and seat so that we can start. My name is Annick Ducharme. It's a pleasure to be with Dr. Zirat.
Yes, this Annick Ducharme is the Vice President of the Canadian Heart Failure Society. I'm Shelley Zirat, the President of the Canadian Heart Failure Society, and this is the first ever Canadian Heart Failure Society accredited symposium at CCC, and we're very pleased to present this to you. We're also, I believe, going live as well today. And so thank you all for attending. I think this is a very hot topic, and we have some international perspectives today as well. So we've already introduced ourselves. We were part of the planning committee for this session today. And these are our faculty.
So if you want to stretch your neck, the faculty are there. We're really, really fortunate to have all introduce them all at once. Professor Jérôme Bax, who's the immediate past president from the ASC. He's director of non-invasive imaging and director of the Echo Lab at Leiden. His main interests include clinical cardiology, heart failure, and CRT. He has authored so many papers that it will take an hour to read his CV, but I think he's very well placed to talk about using imaging to guide therapy in cardiac amyloid, which is going to be the second thought. The Dr. Sarah Cuddy, which is cardiologist at the Brigham and Women, very good institution where I trained. She started cardiology training in Ireland and completed in multimodality cardiac imaging at the Brigham. with, and that was followed by a dedicated fellowship in amyloidosis. So she worked with Rodney Falk, and can you think of a better person than Sarah Cuddy to speak about emerging strategy to treat and manage amyloid? And the international speaker, or almost, because as this is Quebec, we have Vera Brill from Toronto, who's a professor of medicine and neurology at the University of Toronto, and she's director of the neuromuscular section division of neurology at the University of Toronto. She serves as division director of neurology at UHN, and she's gonna talk about when ATTR gets on your nerves, a primer on ATTR neurologic involvement for us cardiologists. And the last but not the least, we have Margot Davis, who's really our champion in amongst our 2 or 3 champions on amyloid in Canada. So she's cardiologist at Vancouver General and St. Paul's, and she did her training at UBC and then completed her advanced heart failure transplant and cardio-oncology amyloid fellowship at Stanford. So I think we have an excellent panel, and Margot is going to talk about the CCS-CHFS position paper on amyloid. So without further ado, I think
we just have a few business slides to go through. These are our disclosure slides for our faculty members. These are our learning objectives, which you'll also see on the CCC app, which we're asking that you all open up and use. We will be using the app for questions. This is an accredited event, and you get Section 1 credits for it. The program was developed by the Canadian Heart Failure Society and was planned to achieve scientific integrity, objectivity, and balance. And the program was made possible through educational grants from Akcea, Alnylam, as well as Pfizer Canada. Again, a reminder of how to use the app that we hope you've all been using, and we will be monitoring for questions as well. And there are some questions loaded in there as well. I believe we might be getting, are we getting Section 3 credits for this one as well? So there are questions in there that you may want to have a look at. And so I'm going to call up Dr. Cuddy to start us off on this exciting session we're having today.
Okay. So great, thank you very much for the invitation to speak here today on the emerging strategies to treat and manage amyloidosis. So I'm a cardiologist in the amyloid program at the Brigham, and it's really a privilege to go first and give the introduction to cardiac amyloidosis in general. And then this talk will really be a focus on transthyretin, TTR cardiac amyloidosis. And I'm going to shamelessly plug a later talk I'm giving where I'll touch on AL amyloidosis. So if anyone has burning questions about light chain amyloidosis treatment, they can come to my next talk this afternoon. So first up is a polling question. So what is necessary to start medical therapy for TTR? And we're just saying TTR amyloidosis in general. Does it require a biopsy? Does it have to be an endomyocardial biopsy? Can it just be a positive PYP or DPD scan alone? Does the patient have to have a TTR mutation? Do they need a UPEP or an SPEP to be normal to start TTR medication? Normal free light chains, or does it have to be all of the above? So can people...
Yeah, can you just advance to the next slide?
Okay, yeah. So... Oh, I have a few for all of the above. So this question's going to come up at the end again. And just to kind of reassure you, there's no definitive right answer here, but there's kind of a few right answers. So it's just kind of food for thought before we start. So like I said, I get the joy of kind of giving the introduction into amyloidosis. So what is it? Well, it's protein misfolding. So it's really defined by the precursor protein that misfolds and forms the amyloid fibrils that then deposit in the extracellular space of the organ, which causes the organ dysfunction. So in cardiac amyloidosis, you can see here it affects the heart, causing thickening of the left ventricle. And we see this really bright appearance as well on echocardiogram, causing a restrictive cardiomyopathy. And here we can see 2 typical staining techniques with the amyloid in the extracellular space. So for cardiac amyloidosis, the two main causes we focus on are transthyretin, being the transthyretin protein is the precursor protein, and light chain amyloidosis. Then there are some rarer causes, which really are hen's teeth in an already considered rare disease that we won't dwell on today. But TTR itself can be further divided into wild type or mutant or hereditary. We'll kind of use a few different nomenclatures intermittently, so I'll either call it mutant, hereditary, or familial, and it kind of varies on how I'm feeling. Sometimes I might even just say hATTR, so I apologize if I cause any confusion with that. So to look first at TTR, what's the mechanism behind the pathology? So the TTR protein is created, it's made in the liver. And it's ubiquitous. We all have this protein in our circulation. We know that it transports thyroid hormone and vitamin A. So once in the circulation, that's where the issue can arise, that it becomes unstable and breaks into these individual monomers from its tetrameric form. And it's these monomers that then aggregate, misfold, cause the amyloid fibrils that then deposit in the myocardium, but can also deposit in the nerves, the peripheral nerves, the autonomic nervous system, and also in the tenosynovium, so carpal tunnel syndrome, spinal stenosis, rotator cuff injuries. And what makes the protein unstable? Well, for the hereditary form, we know it's a single point genetic mutation on the TTR gene, and there's over 120 of these that have been described in the literature that causes this protein to become unstable. And then in the wild type form, it's spontaneous, associated with aging, so we don't really fully understand the mechanism there. Light chain, just to touch on it briefly, is a plasma cell dyscrasia. So it's a totally different precursor protein. It's the light chain. So an abnormal plasma cell clone produces an excessive amount of an abnormal free light chain. Predominantly, we see this being the lambda free light chain as opposed to the kappa free light chain. So that's why it's very important, as well as an SPEP or UPEP, to do a serum free light chain levels when looking for this disease. And it's these light chains that aggregate together, forming the amyloid fibril. And these also have a toxic effect as well. It's particularly seen in the light chain amyloidosis, which portends probably some of its worse prognosis than TTR amyloidosis. So here's just a table kind of going through these subtypes. And really what to emphasize from this, in the mutant or familial or hereditary TTR, there are some common genetic mutations. One of them is this V122I, so isoleucine 122 is kind of how we refer to it. And we know that the prevalence is about 3.4% of African Americans or African Caribbean ancestry have this genetic mutation. So it's out there, a lot of patients with this genetic mutation and predisposition for hereditary TTR. And the different mutations kind of cause a different manifestation, either predominantly cardiac, as we see in isoleucine 122, a mixed phenotype, which we can see in the ALIS60 mutation, which can be a combination of neuropathy and cardiomyopathy. And then there's the MET30 mutation, which is predominantly from people of Portuguese ancestry, where we see a younger onset neuropathy, but there's also people with the MET30 mutation from Sweden, Japan, where it's older onset in cardiomyopathy. So it's a very interesting kind of distribution across predominantly cardiomyopathy or neuropathy in the mutant type. And then again, in the wild type, is to emphasize this is older men that are really affected by this disease. And again, carpal tunnel, as I said as well, spinal stenosis, biceps tendon rupture. We find a third of these patients have a history of a biceps tendon rupture. And also these carpal tunnel tenosynovium involvement is seen in the mutant form, particularly isoleucine 122. So these are some of the clinical clues that I've mentioned: older onset HFpEF patients. So what's really helped us see this is the use of bone scintigraphy with the agents PYP, as I mentioned before, or DPD. So patients that we previously would have needed a biopsy to prove a diagnosis of amyloid, we can now prove that they have amyloid just with bone scintigraphy alone. So we're able to detect it in these elderly populations where we wouldn't have looked for the disease as aggressively as we can now. So the HFpEF population, in one study they saw in 13% of patients over the age of 60 with HFpEF and increased wall thickness, they had a positive DPD scan. And we see similar results with the TAVR populations, where 16% in the Columbia group referred for TAVR had a positive PYP scan. Really important to take a family history of neuropathy or cardiomyopathy. And then as I said, neuropathic involvement occurs predominantly in the hereditary form, and we see autonomic neuropathy as well with orthostatic hypotension that can be very marked. This can also be seen in light chain amyloidosis as well. So important to see. Beta blocker intolerance is pretty common. People just report a real fatigue. And actually, that's one of the most rewarding things about being a cardiologist, seeing patients with amyloidosis, is that you just stop their beta blocker and they already feel better. Then the ECG. So one of the kind of true myths, I suppose, is this low voltage. For sure, it's a real thing, but just because a patient doesn't have low voltage doesn't mean it's not amyloid. So we definitely see, especially among the wild-type TTR patients, patients who have LVH as per ECG. So it's not a kind of ubiquitous finding, the low voltage finding on ECG. So once you suspect it, it usually will lead to an echo or an MRI, or an echo or an MRI will have led to the suspicion of cardiac amyloidosis. So what's next? And really the key point here is ruling out light chain amyloidosis, because this is the emergency that needs to be treated rapidly. And that's by performing SPEP, immunofixation and free light chain assay. So if there is a plasma cell dyscrasia, then it's really vital to do an urgent referral to hematology oncology for bone marrow biopsy, and a biopsy looking for amyloid deposition and typing of that. So it's really essential to type the amyloid, not just to say, we have light chain abnormality, we have amyloid, let's go. It needs to be typed, because we do see patients who have kind of both processes ongoing. So if there's no monoclonal gammopathy, then it goes to PYP and DPD. So either if there's no uptake or trace uptake, grade 1 or grade 0, cardiac amyloidosis is unlikely. We still put the caveat in there. If you still have a high clinical suspicion, it's okay. It's considered reasonable to go for an endomyocardial biopsy, which is an approach we often take if we have these complex cases. But if you have no plasma dyscrasia, a positive PYP or DPD, and a strongly positive scan, then you can go ahead and treat as TTR. And then genotyping comes in. So you do a genotype to see if there's a genetic mutation. If there is a genetic mutation, you've got mutant TTR, which has implications for the therapies that are currently available, and also implications for the rest of the family, children, offspring, siblings. So to go to the therapeutic options, where in the mechanism can we go? So first we're going to focus in on the TTR protein itself and the circulation. And is there a way from preventing it to become unstable and breaking apart? So that's these stabilizers that we have. So the first stabilizer that we had was diflunisal, which is an NSAID, kind of freely available NSAID, which was repurposed for this result. It was seen in vitro to work to stabilize the TTR protein. So the only randomized control trial has been in familial amyloid polyneuropathy, but not in cardiomyopathy. There it was seen to improve quality of life relative to placebo. But there are, and we definitely have treated patients in the past with TTR cardiomyopathy with diflunisal, but there are the kind of side effects that really limit this, such as fluid retention and renal impairment. Then we have tafamidis, which I'm going to go into further, and AG10, which is another TTR stabilizer, which is undergoing phase 3 randomized controls trial at the moment. So tafamidis, this is what all the excitement was really about in TTR cardiomyopathy last year. In 2018, when this was presented at the ESC by Matt Maher, and also with simultaneous publication in the New England Journal of Medicine. So here I have a slight typo. I've said randomized 2-to-1. It's actually 2-to-1-to-2. So they had patients either on 80 milligrams, 20 milligrams, or placebo, followed over 30 months. And here you can see that the curve separates. So this drug reduces all-cause mortality and CV hospitalizations. So we see a significant proportion of patients are surviving longer on tafamidis with TTR cardiomyopathy. So this was the first randomized control trial for TTR cardiomyopathy that showed improved survival at 18 months. And then when we kind of delve deeper into the data, we see that it's really the class 1 and 2 patients who benefited. So detecting this disease early is crucial, and treating it early is crucial. Class 3, we see they had more CV hospitalizations. It was postulated by the authors that maybe they had more hospitalizations because they were surviving longer. So it's living longer with class 3 heart failure. Their secondary endpoints were 6-minute walk test and quality of life scores. And here we see, before the 18-month separation of the curves that we saw with mortality, we see a 6-month separation of the curve. So patients there's not an improvement here, and this is a really important thing that we have to counsel our patients on. They're not going to feel better, they're just going to hopefully feel the same. But we can see here that the patients on placebo got a lot worse a lot quicker than the patients on tafamidis. So the next target is the liver itself. So really in the 90s they started doing liver transplantation, predominantly for the patients with the MET30 mutation. But as you can imagine, there's multiple limitations to being able to do liver transplantation for this disease. So now we're in the era of gene silencers, or TTR-specific oligonucleotides. So there's two agents kind of out there at the moment that have been trialled in familial amyloid polyneuropathy, and these are inotersen and patisiran, and they work here at the level of gene transcription. So they target the messenger RNA and they cleave this apart so the protein can't be formed. So we're stopping the production of TTR protein at the level of the liver. So as I said, this has just been trialled in familial amyloid polyneuropathy. Some of these patients do have a cardiac overlap, but it's not in the wild-type cardiomyopathy like was trialled in the Attract tafamidis trial. But here we see some really intriguing data for their endpoints, which was the neuropathy impairment score and Norfolk quality of life score, where we see a significant change, stabilization in the patients on treatment, and even in the patisiran, there's this signal that there might even be improvement on therapy in these groups. So a pretty exciting outcomes in the world of TTR amyloidosis. And here's kind of further data from the trials. So we see on the, I think you're on my, yeah, on my right, the level in TTR. So we see a 70% reduction in TTR levels in circulation. And we're actually conducting at my centre a single centre open label study of inotersen in all types of TTR cardiomyopathy, hereditary and wild type. And we're seeing similar reductions in the circulating TTR levels. We don't have enough kind of longitudinal follow-up to know what changes we see on echo or MRI, but there has been subgroup analysis done of the Apollo trial, so the patisiran trial, which showed us some really intriguing data where we saw a possible reduction in wall thickness. It's just millimeters here, so those of you who read echo kind of know a millimeter change on echo. It can be hard to see clinically, but compared across this population, placebo versus control, there was a significant difference. So it's pretty intriguing, and there was similar data published with their strain data. So it's early data, but it's giving us kind of a lot of excitement of what will kind of occur with the cardiomyopathy dedicated trials which are being planned. So just a few notes on heart failure management in general. Avoid beta blockers. Sometimes this can be really hard because these patients have very difficult to control atrial fibrillation. So it's really as low a dose of beta blocker as possible, and preferably none. These patients don't tolerate ACE inhibitors. Torsemide is really our diuretic of choice. The bioavailability and gut absorption of torsemide really favours it over furosemide. We actually find spironolactone quite a helpful agent as well, in addition to torsemide, and I can't stress the salt restriction enough. Midodrine is useful in those with a clear orthostatic hypotension. There is a role for heart transplant and LVAD, but that's definitely another day's talk. And then when pacemaker is required, we often refer these patients for a CRT device. That's meant to be CRTP, not CRTD. So the challenges really with this disease are early diagnosis is key. The costs of these medications is a huge consideration. The administration, I didn't really get into the differences between patisiran and inotersen, but patisiran is a subcut injection and inotersen is an IV infusion. So this can be a challenge for some patients. And then we don't really know the long-term effect of what having minimal TTR protein will be. So back to the question, if you want to answer again after that kind of quick overview, I don't know if you can re-answer the questions, but we'll go through it. So biopsy proof of amyloid from anywhere, yeah, if you have biopsy proof, but as I mentioned, it needs to be typed. So just so you see amyloid doesn't mean that you know what type of amyloid it is. It's really key to type it, and mass spectrometry is gold standard. Endomyocardial biopsy is really for those cases where there's uncertainty. A positive PYP scan has to be in the context of normal SPEP and normal serum free light chains. And then it's really key to do genotyping once you have a positive PYP study or a suspicion of familial TTR amyloid. So that was a very quick run through. I hope I haven't left anyone too confused, and I'll pause now. Thank you very much for your attention.
Super. Thank you so much. We have a little bit of time for some questions. Again, can you just review which meds are IV or sub-Q?
Yeah,
or
sorry. I wanted to I'll go back. I wanted to talk about that more in the slide. I was worried I was going to get caught for time. So here are the two gene silencers. Patisiran at the moment is an IV infusion, so it's given 3 weekly. So patients come in for this infusion, and it usually takes the best part of the day. Inotersen is a subcut injection given on a weekly basis. The big thing that I did want to mention, I'm glad you've pulled me up on this, is the safety concerns over these drugs. So tafamidis had a great safety profile, really no major adverse events. Inotersen is where there was some concern with the study with thrombocytopenia and also glomerulonephritis. So there is a warning on the label of inotersen in regards to this. In the open label study that we're conducting at our centre, where we already have close to 30 patients enrolled, we've definitely seen a drop in platelets, but no major bleeds. So we're monitoring patients' platelets every 2 weeks and occasionally weekly. And then we're also monitoring their renal function. We've seen no glomerulonephritis.
Okay, so you have a monitoring algorithm for those patients then?
Yeah, and it's kind of as per the label as well. I think it even might be more frequently. I think as per the label in the US, it's weekly monitoring, but we're doing 2 weekly as part of our clinical trial.
Okay. Well, thank you. Have a seat up here because I'm sure there's going to be plenty of more questions for you. And at this point, we'll call up Professor Bax, who is going to be presenting using imaging to guide therapy in cardiac amyloidosis.
Thank you very much. It's a pleasure to be here with you. I have always a special feeling for your country. We've had the opportunity to work with a lot of people in your country, and I was happy that I could establish and strengthen the relationship between the European Society of Cardiology and your society. I always feel when I come here that you and we think very similar and we act very similar. So although I arrived only this morning, I feel quite at home. So you asked me this question, like how to monitor therapy. I think personally that's very difficult because we don't have any technique that really allows us to monitor therapy, and we also don't know what we're talking about really. So I put my slides nowadays very, very simple. So we talk about 2 major types of disease. The one has a very short-term survival and the other one has a longer-term survival. And if we then talk about imaging, then the question is what can we use for technology? So the ones of you who work in imaging on a daily basis, all that we use is echocardiography. And the nice thing of echocardiography is you can use it again and again and again and again. So if you talk about monitoring, that's probably going to be the technique of choice because you can repeat it as much as you want. But you saw the data from Scott Solomon. I saw this last year. The standard deviations are huge, and the differences are so small that I personally believe that echo is probably not the tool that can monitor these small differences for you. If you measure an ejection fraction in your laboratory and you ask another guy to do that, the differences can be ranging from, let's say, 5% to almost 10%. And so I think you got to be careful with what sort of technique you use. So CMR is another technique that we can use, very high resolution, quite reproducible, but it's not the technique that you put the patient in every week. To understand this, at some moment I did an MRI myself, and I tell you it's not fun to sit in this tube for 1 hour. So nuclear imaging is more for diagnostics. So you can do planar imaging, you can do SPECT, you can do PET, but I think the nicest tool that we have nowadays is this fusion imaging. This fusion between the CT on the one hand and merging that with the nuclear data on the other hand. What information can imaging give you? I think that I've been thinking long about this, and I think we have three sorts of information. One sort is anatomy, that is size and shape. Then we got the functions, which are ejection fraction or diastolic function, very simple. Echo is doing that. Echo is different than CMR, which is much more focused on anatomy, but also very focused on function, which might higher resolution. And nuclear imaging, I put between these things inflammation to target your specific disease. So I think that is probably one tool that we should use more. And if you merge that with CT, which has a very high resolution for anatomy, then probably you strike a good balance. So if we talk about amyloidosis, the clinical presentation, heart failure, preserved ejection fraction, and the imaging techniques that I think that are mostly available and are in some way repeatable is echo, 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 and then to some extent CMR. I think you look for normal ejection fraction, you look for septal hypertrophy, you can also look for concentric hypertrophy. You see what I put there between the ATTR is mostly septal, the concentric is in the AL type. You're looking for a thickened ventricle, reduced forward stroke volume, LVOT obstruction sometimes. There can be a gradient, just like in HOCMs. And I think we start to realize more and more that it relates to other diseases, such as what was already mentioned in the very elegant talk before on the relation with low flow, low gradient aortic stenosis. I don't completely understand how this is pathophysiologically working, but we see it also. I've looked at our big databases where we have about 7,000 severe aortic stenosis, and we also have a lot of these low flow, low gradients, and you see it. It's there. And then we come to the fibrosis. The fibrosis is probably the thing that MRI is the best tool for. So if we talk about targets of imaging, I like this review from Shamila Dorbala, where she actually lines out quite clearly to you like what can we measure. We can measure hypertrophy, and if we look at here, this slide on my left, the true LV hypertrophy, that is what you see with the ECG. But if you have the increased LV mass without hypertrophy, is what was mentioned before, these very, very small complexes is quite useful. So a simple ECG gives us a lot of information. Then, of course, there is this fibrosis and this amyloid depositions. If it's inflammation and you're looking for that signal, then you take the nuclear amyloid tracers, as pointed out there. So with SPECT and with PET, we have that 118F tracer, which is always a good tracer because the half-life is about 110 minutes, so it's a very strong signal. And then to the lower right, you see the increased LV wall thickness. We use CMR and echo, and there's only one that can look at expanded ECV, and that's CMR. So echocardiography is the mainstay, and Shamila in her article called that the red flags. So if you have patients with heart failure, preserved ejection fraction, and you start to see these things, a little bit of effusion, that's what you often see. You see already sometimes something on the right ventricle, and I give you 3 examples at the end of this talk of my own echo department. Thickened valves, I think we don't see that too often. Low stroke volume, that's very clear. And the paroxysmal low flow, low gradient, I think in 15% of those patients you can find that. This is very simple also to derive from echo, so the mitral inflow Doppler, the pulmonary vein Doppler, and the lateral or also the septal tissue Doppler show that very, very low excursions. So sort of the abnormal relaxation and the low systolic velocities. This is the one. This is the one that we started working with maybe early 2000s. And I think this is a technique that shows the thing so clearly. I'm going to take you through that in a second. So CMR, fibrosis is probably important. And what I see in our cases, what I point out to you here, in the middle row, you see that the fibrosis, the diffuse fibrosis that's taking place, the increased ECV really makes these images a bit blurry. And that is actually the hallmark, I think, what CMR brings you. So then, of course, we got nuclear scans where you see the hotspot, and we spoke about this grade 1, 2, 3. And what was very nice to hear in your talk, and I'm a strong believer of those things, that everything we see, you need to treat earlier, 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 earlier. So in heart failure, we wait endlessly before we go to a mitral clip. But I think we need to treat earlier and to treat more aggressive, and that's probably the same here. This is the PET and the SPECT-CT pictures. This is, in this case, the SPECT-CT, and you see that the fusion of those two makes very nice an inflammation, if you like, signal versus a anatomical signal. And this is the same with the PET-CT. So this fusion imaging is probably the way forward. Now I'm going to take you to the cases that I just selected from our department. So this is very clear, female, 70-year-old, and she presents with dyspnea. Most of them present basically with dyspnea. You do an echo, first step that you do, and you see this very thickened ventricle. The ejection fraction supernormal, 66%. You see a very high EA ratio, deceleration time of 273, and the E over E prime is very high filling pressures. Very simple things to measure. But this is what I said to you, what is going to make the difference. Because this is very easy to do, this strain mapping, and this is the longitudinal strain, so it's the up and down strain, if you like. And what I like to see is these polar plots there on the right, just like a nuclear polar plot. And you see that the very red, the dense red in the center, is where the strain is preserved. And at the apex is where the strain is preserved, and the rest of the part, all the strain is gone down. You get then a number that says GLS, which is global longitudinal strain, and global longitudinal strain normally is around -20. The minus is only because it's an up and down movement. For the rest, forget about the minus. But 20 is a normal heart and has a normal ejection fraction. But normally, if you look at the patient with acute infarction, significant infarction, he has a global longitudinal strain of maybe -13, which means an EF of about 40%. But this is very striking. They have a normal EF and they have a significantly reduced global strain. What we see is that the relation between ejection fraction and strain is good, but it's certainly not perfect. So strain gives us some more. In most of the diseases, it's a reflector of the fibrosis. It is a very important prognostic factor, and you see here that the patients with normal strain on the right side of the Kaplan-Meier, the top curve, has a relatively preserved strain. They have a relatively good outcome. The one where the strain is all the way down, that does not have a good outcome. And that tells me that if we want to monitor anything with a reproducible technique that we can do every day if we like, it's going to be echo with strain. I'm going to show you two more and then I'm finished. So this is a man 68 years old presenting with shortness of breath, and you see here extreme clear picture again of what I just showed to you. This is another patient, and you see here the beginning in 2011. You see the global longitudinal strain with this preservation in the apex and the rest going down. The strain is at that moment in time, now I need to look, this is -11 it says. So it is already significantly reduced. And sorry, you see the MRI there. You see the MRI on the bottom right, and you see that the short axis is blurry and is not very well defined and is a bit whitish. And that's the diffuse fibrosis. When you get this sort of images, you know that it's significantly not good. This is the situation in 2013, where the global strain is now going down, or no, is staying around the value of 12. But this is what the natural history is. This is before we had any treatment. You see the RV, look at how bad this ventricle looks. There's some effusion, it fits all the characteristics that I gave you in the beginning, and now global longitudinal strain is way down. It's very, very low, below 7. And actually, what I want to give you, if that you want to monitor your therapy, in my opinion, there's only one thing that can do this, is this. Because this I can repeat every day, the resolution is fairly okay, and the reproducibility is fairly okay. Thank you very much for having me here. My conclusion is only echo strain.
No, you have to come up.
So I do have a question from the audience that I'm going to add in here, and we'll ask Dr. Brill to come up as I ask the question. And so if the creatinine clearance prohibits the administration of gadolinium in patients with suspected cardiac amyloid, how useful is T1 mapping on the cardiac MRI? And if it's normal, do you proceed with nuclear imaging?
Yeah, I think, is this working? Yeah. I think you use this for diagnostics. And for diagnostics, it's quite good. It's not specific. It's a sensitive technique that shows that something is wrong, but it's not specifically telling you that this is the case. And so I think putting the things together is really what makes it. So you need an ECG, basically, you need a good clinical history, and the echo plus the MRI gives you the full picture. I think this is a good technology to use it. In our opinion, it works quite well. Yeah, but I like this combination. Just to give you one example, we have a study going on, and every Wednesday we talk about the patients that are being enrolled, and then one is presenting them, and the others, it's on the phone, so we see all the pictures, etc., and then we discuss if these patients can be included. And it's about the shunting device between the left and the right atrium. So we discussed one the other day, and this patient had a carpal tunnel syndrome. The ECG shows these micro voltages, and somebody said probably this is amyloid. It's not just pure HEF what we're looking at. And so if you get to know your signals, you also start to look for them.
Yeah, to speak specifically about T1 mapping and non-contrast MRI in the diagnosis, there is a lot of publications really from the London group on amyloid, and they published on just the use of non-contrast MR alone. T1 mapping is a challenge because it really depends on your own scanner. So you need to know what the normal results are for your own scanner. It's hard to kind of take that cut off from the literature, a 3T magnet versus a 1.5. And even the reproducibility with T1 mapping is challenging to make a definitive diagnosis. Where with ECV, which is the T1 mapping pre and post contrast, we can be very certain that when we see a global ECV greater than 40%, it's very much significant correlated with cardiac amyloid. But the T1 mapping is more of a challenge. So it's exactly what Dr. Bach said. You'd want to know the rest of the clinical context. And if you have really good echo strain available or a nuclear medicine department that can offer other alternatives, it'd probably be the best way to go.
Yeah, but I add to that, really look at this as a clinician. So you see the clinical picture, and then you bring these things together, very simple thing as the ECG, the clinical history, then you get your echo, because that echo that I showed you, I can show many other diseases that show exactly the same. So you need the clinical context. And then if you can combine that with an advanced measure of an MRI, you get a pretty good phenotyping of the patient.
Talking about clinical content, I think neurology can help us very much try to pinpoint our patients. So welcome, Dr. Brown.
Thank you.
We're trying to get rid of the noise next door.
Yes.
I'm sorry.
Thank you very much, because I'm hearing that as I'm trying to speak to you, and this is too much multitasking. So I'm talking to you now about when... There? Can we all hear me now? I'm talking about when ATTR gets on your nerves and what we have. And I'm really talking about the hereditary form, because the senile form that you see so much in cardiomyopathy, we do not see in neuropathy. When we do polyneuropathy, we might find a monoclonal gammopathy when we do an SPAP. In that case, we send the patient to see a hematologist, but mostly it's a monoclonal gammopathy of unknown significance, and amyloid is not being deposited in the nerves. This is in contrast to the very rare light chain amyloidosis that you heard about, and of course the hematological malignancies that cause polyneuropathy and light chain disease. So my question, very simple, are chronic headaches a symptom of polyneuropathy? True or false? All right, so true. All right, so we're kind of 1/3, 2/3 for a headache being a symptom of neuropathy. So let me go on. And it's not advancing. Oh. I just wanted to show the hereditary amyloidosis mixed pattern of the different genetic mutations and whether they're prominently cardiac or neurologic, but mostly they're mixed. And we're now seeing, as I share patients with Diego Delgado in Toronto, we're seeing that patients often have both things going on, but predominantly one or the other. And Val30 is our big peripheral neuropathy one. And this shows you the multi-system involvement, and in red you can see the neurologic manifestations of the peripheral neuromuscular system. I am not a stroke neurologist or a brain neurologist. I deal with the nerves and muscles. So I have highlighted those things. There are some CNS manifestations, but they're less common, and I'm not paying attention to them today. But carpal tunnel syndrome, peripheral neuropathy, sensory motor, autonomic neuropathy, and then people will argue about spinal stenosis, let me say. So the clinical presentation that is typical is a symmetrical, length-dependent peripheral neuropathy. The symptoms initially start distally in the lower limbs and progress upwards to involve areas above the ankles, into the knees, thighs, and also arms and anterior trunk. Early, there is numbness and pain in the feet with impaired temperature and pinprick, and strength and reflexes are preserved. But the sensory loss progressively increases, and light touch and deep sensations become impaired. This is the pattern in diabetic neuropathy, alcoholic neuropathy, many toxic neuropathies. This is not specific, but it is something you might want to pay attention to if you have a patient with cardiac amyloidosis, because this might be an indication, especially the pain in the feet, that they have amyloid polyneuropathy. And then the balance becomes impaired, a gait is compromised, they get clumsy, and they get autonomic dysfunction. And sometimes the peripheral neuropathy is not evident, but they get the autonomic features that I've listed of alternating diarrhea and constipation, anhidrosis, nausea, delayed gastric emptying, vomiting, ED, urinary retention, and incontinence. And autonomic dysfunction can occur very early, and I have patients sent to me with orthostatic hypotension. Are they POTS? Are they autonomic neuropathy? And as you know, as cardiologists, is it drug-induced or is some iatrogenic? Weight loss is common in amyloid polyneuropathy, which is something that I was reminded of, and muscle wasting is also common. We stage the neuropathy, and the simplest is the top level, 1, 2, and 3. 1, they walk without aids. 2, they mobilize with aids. And 3, they cannot mobilize. They're in a wheelchair or they are in bed. And the amyloid studies that you have heard about with patisiran and inotersen enrolled stages 1 and 2 patients, not stage 3. It is uncertain that the benefits that have been seen in stages 1 and 2 would translate into stage 3, but of course we're all going to put patients in stage 3 on the medication. If you are, we no longer are referring patients for liver transplant, but if you were, they wouldn't be taking patients in stage 3, and of course they wouldn't take patients with any significant cardiomyopathy. Now, carpal tunnel syndrome is a special consideration in men, I would say, in younger men. But you know, carpal tunnel is very common, and especially in women, pregnant women, fluid retention, different renal failure. Carpal tunnel is a very, very common disorder, and most are not going to have amyloidosis or familial amyloidosis. But in one particular study, 10% of biopsied connective tissue had amyloid. So that's a discussion to have with the hand surgeons, the plastic surgeons, whether they will take a little bit of connective tissue and send it for amyloid staining. So my key point in all of this is remember the nerves. You know, I mean, remember the nerves. If they have numbness in their feet and pain in their feet, you know, ask the questions, because maybe the patients won't tell you. You have to ask if they have these things. If they're unsteady, if they have symptoms in their hands suggestive of carpal tunnel. Of course, you're very much more attuned to orthostatic hypotension than not, but you know, don't forget to ask about it, and syncope. And those are the points really for me, that you just have to think about the nerves. Remember way back when you did neurological assessments on your patients, and maybe do a little bit of one and send them to a neurologist, a neuromuscular neurologist, for further assessment. Thank you.
Wonderful. Oh my goodness. Thank you. For the sake of time, I think I'm going to have you take a seat, and we'll await some of these questions regarding the neurologic findings of ATTR. You know, it's certainly eye-opening for many of us cardiologists to have a neurologist at our national conference. And with that, I'd like to call up Dr. Margot Davies.
Thank you. Thank you so much for inviting me to speak today, and thank you all for coming. This is an incredible turnout. I know it keeps going too low for me.
You have competition next door.
There we go. Yes. All right. I think that will work. I'm going to shift gears now a bit and get away a bit from the science and the clinical medicine. However, oh good, my title has been revised. Those of you who thought I was going to be talking about the position statement paper, I invite you to join us at 4:30 tomorrow afternoon to hear more about that. But I'm going to just talk a little bit about the Canadian context and where all of the things you've heard about so far fit into that. So there is a lot going on in Canada related to ATTR cardiomyopathy. We do have a joint CCS-CHFS position statement that will be presented tomorrow afternoon. The availability of diagnostic testing is evolving in Canada, and you've heard a lot about how things are changing, the fact that we don't need biopsies for the vast majority of our patients anymore, and slowly we're seeing that more and more centres across Canada have access to nuclear scintigraphy, and therefore their patients can take advantage of that important resource. We do have access to these novel therapies in Canada as well. I'll talk a bit about that. And more therapies are going to be studied in upcoming trials in Canada and beyond. There are funding considerations that I think need to come into any discussion of where these fit into in Canada. And finally, I'll discuss the registry for amyloidosis research briefly. So as I've alluded to, there is a joint position statement on the evaluation and management of cardiac amyloidosis. This is scheduled for publication in the Canadian Journal of Cardiology in March 2020 as part of a focus issue on cardiac amyloidosis. Our position statement is going to address key aspects of ATTR management, including warning signs to alert you to the possibility of the disease, an approach to diagnosis and imaging findings, an approach to the management overall, and in particular the use of novel disease-modifying therapies. And as I mentioned, this will be presented tomorrow in a dedicated session at 4:30 in the afternoon, and I hope you all will be able to join us. The availability of diagnostic testing is an important issue for many of you. The tests that are used to make this diagnosis are not tests that most of you have been using prior to this for most of your patients. So until now, probably very few of you are routinely ordering serum and urine protein studies on your patients, but it is really important when you see a patient with possible cardiac amyloidosis that you rule serum and urine protein electrophoresis with immunofixation, as well as serum-free light chain studies, because as you've heard, AL amyloidosis is an emergency that needs to be diagnosed as quickly as possible so that effective therapy can be instituted as quickly as possible. Now, many clinicians do have difficulty accessing some of these tests, in particular the immunofixation. I and others have had to get in arguments with our various labs in the hospital and outpatient labs to explain why it's important that immunofixation be done, but really the sensitivity of a plain serum protein electrophoresis and urine protein electrophoresis may not be high enough to diagnose this. So I would just simply urge those of you who are having trouble with this to just reach out to your local pathologist, have the discussions, and hopefully make some headway that way. Pyrophosphate scans are another test that were not routinely being ordered by cardiologists or really anybody for the last several years, but these are increasingly available, and in my amyloidosis clinic I'm seeing patients referred from around British Columbia, towns with populations of 30,000. Their local hospitals are now doing these tests. It's really a question for the most part of talking to your nuclear medicine colleagues, explaining the test and why it's going to be useful, and then the nuclear medicine can access this radio tracer through a couple of different options. It is made locally at a few centres in Canada, or it can be imported from the United States through special access program because it's not actually approved by Health Canada. But this is really important that this be more widely available. Something to keep in mind, though, is that there is a bit of a learning curve, I think, for the nuclear medicine physicians as they sort of get to understand what is and what is not cardiac amyloidosis. It is actually a fairly straightforward grading system. There are quantitative and semi-quantitative methods for grading it, but there is the possibility of false positives, and it's important that you understand and that your nuclear medicine people understand exactly what it is they're looking for, what's a positive test and what's not a positive test. Endomyocardial biopsy, of course, is routinely available at certainly any center in Canada that does transplants, and many others as well. And this is still needed for the small proportion of patients who have abnormal serum and urine protein studies. So if you need to get it done, any transplant center will do it, but many cath labs elsewhere can do it as well. Immunohistochemistry is not widely available. This is one of the tests that's used on biopsy specimens to type the amyloid. This really needs to be done in an expert lab, and so you may just bypass this step and go straight on to mass spec, which is the other way of typing the amyloid on a biopsy. This is only available, as far as I know, at the Mayo Clinic and more recently in Toronto. So you'll need to send this out, but your local pathologist can arrange for this. Now let's go on a little bit and talk about the drugs that are available in Canada. I really only have a minute left. Yep. Oh my goodness. Okay. So patisiran and inotersen are both approved for use in hereditary TTR with polyneuropathy in Canada. It's important to know that these have not been tested, as you've heard, in cardiac patients, but these or next generation agents may be tested in these populations soon. But what we do have for our cardiac patients is tafamidis, which you've heard about. This is not yet approved by Health Canada, but it is available through an open label extension of a clinical trial currently at 3 centers in Canada. Those are Vancouver, Calgary, and Toronto. And so if you want to get your patient onto one of these or onto tafamidis in the meantime, that's where you can send them. But we do hope that this will be approved by Health Canada in the near future and commercially available. There are more options coming. These are 3 trials that are going to be recruiting patients probably at centers in Canada in the near future. So this is a growth industry, the treatment of ATTR amyloidosis. We're hopefully going to have many, many options and potentially be spoiled for choice in the near future. But that, of course, leads to the important issue of cost, and I think it's really hard to talk about this stuff and not mention the cost issues. These are expensive drugs. I think it's really important that our patients have access to them, and I certainly would hope that as it becomes increasingly recognized how common, particularly wild-type ATTR is, that the cost of the drugs comes down, because you know, if this is as common as we think it is, it's going to be tough to find resources for it. For that reason, it's important that we properly evaluate the real-world cost-effectiveness of the novel therapies as well. And to that end, I'm just going to put in a quick plug for the Canadian Registry for Amyloidosis Research. Myself and Noel Fine are co-leading this initiative, and essentially it's a multi-institutional prospective registry of patients with amyloidosis, not restricted to cardiac, really trying to get around the fact that so many centers have small amyloidosis populations, which really limit our ability to perform good observational studies and also limit our ability to recruit patients into clinical trials. So our primary objective is to improve outcomes of amyloidosis patients through an enhanced understanding of optimal diagnostic and management strategies in Canada. But effectively what we're trying to do is just collaborate and be able to better understand this by working together. For more information on this, you can either contact myself or Noel. So just in conclusion, and I'm very sorry, Shelley and Anik, the Canadian amyloidosis providers can expect continued advances in available therapies for their patients through commercially available drugs and clinical trials. Our Canadian amyloidosis community is increasingly well organized, and we are working on making important contributions to the field. But future challenges really include understanding the true burden of disease in Canada, how many undiagnosed patients are out there, and deciding how we can best allocate resources for what are very, very important disease-modifying therapies that can change our patients' outcomes, but that we need to work out the details on resource allocation for. And with that, I will end. Thank you.
So, Dr. Davies, we're actually okay. We have some time for questions that I'm going to tackle from the app here. Question, why salt restrict but give midodrine?
Oh, yeah.
I think it's on.
It's on. That is a great question. So really for the cardiomyopathy patients, salt restriction is key. So a lot of people probably are used to giving a fluid restriction to heart failure patients. We actually don't give a fluid restriction. We just are really stringent on the salt restriction to any of the patients who have heart failure due to amyloidosis, so AL and TTR. We tell them less than 15 100 milligrams per day of salt. And really we find that they're salt sensitive. The minute they go over this, they start to retain more fluid and decompensate very quickly. The midodrine is the autonomic neuropathy patients. So it can become extremely challenging with these patients who have an autonomic neuropathy with profound postural hypertension. This is mainly the AL patients that we see who have this, and it is true, we have them on salt restrictions and giving midodrine to try and negate this postural hypotension because it can be so marked. The other population is the patients with the TTR neuropathy who can get a really profound postural hypertension. Sometimes they mightn't have as much cardiac involvement, and in those patients we're more liberal with their salt and have them on midodrine and even pyristigmine. I don't know if Dr. Burrell has experience with managing patients with postural hypertension due to TTR, but it can be very challenging.
Yes, no, I agree, and this is where I want my cardiology colleagues to step forward and do it with me, especially midodrine because of the supine hypertension, right? So I think I could not do this alone.
Dr. Davies, you have a fairly well-integrated amyloid care pathway, or you're working on one in Vancouver. How do you integrate all the different specialists in the patient's care?
So in Vancouver, we're fortunate that we have myself, we have a neurologist who's very engaged in ATTR, and then we have a hematologist who's very, very engaged in AL, and the three of us work together. We're actually in the process of setting up a formal clinic, but for now we have what we call our virtual Center for Amyloidosis, which is effectively a lot of emails back and forth at this point. But I can't emphasize enough the importance of finding a neurologist and a hematologist that you can work well with, because especially with the ALs, having somebody that you can email and say, can you see this patient tomorrow, so that they can get their marrow the next day and be started on chemo hopefully by next week is so important, because if you're just putting in a referral to a general hematologist and they're waiting 3 months, your patient may not survive to see the hematologist. So that's so important. And with neurology, it's increasingly important to have that relationship because of these drugs. And so I'll have a patient with hereditary TTR who has a mixed phenotype, both polyneuropathy as well as cardiomyopathy. And so now that we have the availability of tafamidis through the open label trial, as well as commercially available other drugs or through trials, we have to kind of decide, is this patient really going to do better on tafamidis, or are they going to do better on patisiran or inotersen? And those lead to really interesting discussions. Well, the patient's father died of heart failure, so I think we should really focus on the drug that's got the mortality benefit in cardiomyopathy, versus this patient has a positive pyrophosphate scan, but class 2 symptoms, whereas they have fairly disabling polyneuropathy. Maybe they're going to do better with one of the other drugs. We really need more data coming down the road to show how these drugs work in these various settings, particularly the mixed phenotype patients. But coming back to it, it's just so important to have a neurologist and a hematologist find one, establish those relationships, and stay in close contact.
Yeah, these are all important care pathways that we're all working on developing in our local centers as well. Unfortunately, I think we've come very close to the end of our program here. I'd like to remind everybody to please fill out their evaluation forms, and a plug for our heart failure update in Toronto, April 17th and 18th. You can go to heartfailureupdate.ca to learn more about amyloid and its effect on the heart. Thank you again for your participation, and thank you to our panelists for contributing your thoughts today.